So it's going to be a big morning. This is my favorite introduction. I don't tell the others, but it is. Because Dr. Alvarado is a friend and neighbor, and she's also an internationally renowned expert in infection control. And she is a research scientist emerita at UW-Madison. And she was an infection preventionist at UW-Madison hospitals and clinics for over 20 years. She did her PhD in engineering, so she has a similar background to Lindsay Steege in terms of focusing on human factors engineering. And the author, Dr. Karian, of that article that you read, that's a Sentinel article. Dr. Alvarado was part of that work for many years and has written some of the Sentinel articles herself. So her research areas include nosocomial infections, safety, culture, and climate. That's such a big part of what we're talking about, right? Safety, culture, and climate. And thinking about these redesign of the human factors and the ergonomics related to healthcare. So with that, I'll turn it over to Dr. Alvarado and enjoy.
Thank you. Let's see. I may need this. I don't know. It's a pretty small room, so I think you can probably hear me. I am Carla Alvarado. You do not call me Dr. Alvarado. You call me Carla. I am retired. That's what emeriti means. And that means that I don't really work anymore, which is nice because I am really old. So I'm so pleased to see a younger crowd that is interested in this, because I would hate to think that I worked all those years and nobody cared. So it is nice to have you here at this meeting for the week, and I know you'll get a lot out of it. I'm also happy to see there's a Chrissy up there, which is my firstborn's name, Christine, and now she is a professor at University of California, San Diego, and whenever I call her Chrissy, it's, Mom, I'm Christine. I'm a tenured professor now. So, but she's still Chrissy to me, so I'm happy to see it spelled exactly the same way. I worked for many years in infection control. We don't call it infection control anymore. Think about it. It's infection prevention. Infection control was a very linear type of discipline where we found infection, worked on it in an epidemiological manner, and then we imprisoned the people who had it, better known as isolation. And it was control. We controlled it with chemicals and keeping people cohorted. We don't want to see it that way anymore. We have a bigger quality perspective that we work to prevent infection before we have to control it. So this morning, let's see what toys I have. I assume that's the one. All right, here's my rule about change and working with people. When those who benefit are not those who do the work, then the technology is likely to fail or at least be subverted. And what I mean by that is you can have the best idea in the world. You can come away from working with your colleagues here and go back to your own institutions and countries. And if you don't get the people who work with you there aware of what you have learned that you want to bring back, it'll fail. Absolutely. You just have to make sure in everything you do that those that you are trying to bring with you on this journey see a benefit for themselves. Because if you do not get the benefit message to them, it won't happen. It won't happen. So what's my international background? You say, oh, that's fine, old retired woman. What did you do? Well, what I did was work internationally, besides working right over here at the big hospital. And this was Almaty, Kazakhstan. One of my favorite projects was working in the newly formed states of the former Soviet Union, helping set up infection prevention programs with the Russians and all of the newly formed independent states, Almaty, Kazakhstan being one of my favorites. But what we did, we brought in in our projects, the women, and it was primarily women doctors who did this, because I don't know, are any of you familiar with the former Soviet system, the Russian system? There were two paths in medical school, one of which you could sort of describe as public health and sanitation, and that was one path, and then the other path was mainly surgery. So these were the ladies who ran the bureau in Moscow, and this was our most important area of change, was to take the former Soviet system, which was punitive. And I might say they weren't alone in that. We were punitive, and we still are, for healthcare-acquired infections. You have only to look at our CMS, our Medicare, our government, to see where we do not pay for infections that are acquired while in our healthcare systems. So we're still punitive. The Russians actually handed out fines to their hospitals. If you had an infection, you will be fined. If we find bacteria on your walls, you will be fined. And our project in the newly formed states of the former Soviet Union was to change that vision to one of prevention instead of penalties. And these were the three ladies that were key to that movement. They were all with the Ministry of Health in Moscow. Even though they were newly formed independent states, Moscow still had a lot of influence on what they were doing. Two people internationally that you may know of. If you do not, you probably, if you're interested in infection prevention internationally, these are wonderful physicians and researchers. Sergei Ehrman was originally from St. Petersburg, but now he's in Geneva at WHO. And Victor Rosenthal is in Argentina, in Buenos Aires, and he probably has the world's largest database of healthcare-acquired infection in a lot of transitioning countries. Victor he's made it his research interest to collect data around the world on the infection prevention programs. So if you want to look up what's happening in a country that might be similar to yours, etc., look at the data that Victor Rosenthal has. I've included some of his papers in my reading list. Interestingly enough, a man from Harvard that worked with us, who's now very retired, collected all of this data in developing nations on newly developing healthcare systems. On antibiotic resistance was a man by the name of Thomas O'Brien, who was a MD, PhD professor of infectious diseases at the Harvard system of hospitals. And he's done wonderful work. But as Tom always said, nobody knows me for my work. They only know me for my son, Conan O'Brien, who's a comedian on American television, who, as Tom said, all of my work around the world in antibiotic resistance has been eclipsed by my son, who's a TV comedian. Papers available in PDF that I sent over for your review. No reason to have to read them now, but when you go home, you'll have them. Why infection prevention policies are important in countries in a phase of healthcare transition. Well, policy making in developing countries is based on anecdote rather than evidence. You know, here we say, but is that evidence-based? There's a little yin and yang in that. Because some of the best ideas that I've ever seen maybe don't come from evidence-based. It may come from someone saying, well, I think this might be a good idea. If there is no evidence, that's where research comes in, and you have to back it up that it's a good idea. But don't always think that you need a clinical trial to know which way the wind blows. Very simply, in Los Angeles and New York City, back in 1981, there was just a case note, just an observation, that there were younger men who had Kaposi sarcoma, which is usually in older men of Mediterranean descent. Why younger men in Los Angeles and New York City at the same time displayed Kaposi sarcoma. Just a note, just an observational note. What did it lead to? HIV. Exactly. So there was no clinical trial there. There were just 8 guys that presented in Los Angeles and 12 guys that presented in New York City. They had one thing in common. They were homosexuals. But, there are far more homosexuals than 8 in in Los Angeles and 10 in New York City. Why? What was that? And that clinical note defined what would go on to be one of our worst diseases the world has ever seen. So don't always think for something to be significant that there has to be a clinical trial on it. It may just be the starting point. Clinical interventions really consume a lot of resources to have that clinical trial, if that is the gold standard of what you're doing. In later life, I'm not particularly wedded to the clinical trial. There are some things that are just obvious, and you can look at them in a way without a clinical trial and a control group. But speaking about clinical trials, and I never did antibiotic research, things like that. That's a clinical trial. But it takes away, and it takes a lot of money from your public health activities. If you're going to look at something, and you have to have a clinical trial, that's some of the most expensive research you'll ever do. And be careful that that is not at the, shall we say, detriment of some really good public health initiatives that you should be looking at while you get your control group and you get your trial group and do a clinical trial. Sometimes in a deprived environment, which some countries that are struggling, the population is fatalistic. And they accept that the disease and misfortune is going to be there in their lifetime, and they're not appreciating the cure and redistribution of resources. From cure to prevention is easy. They look for cure rather than prevention. And as my husband was born in Peru, and his grandmother, a wonderful woman, she had 1,000 great phrases, as most grandmothers do. But one of the things that she always would say is, it is my fate. Well, no, it is not your fate. There are things we can do to prevent these diseases if we look at prevention. In fact, my favorite thing she ever said was, I do not want to wear a seatbelt. And I said, Mima, why don't you want to wear a seatbelt? Because it is God's will. Well, yeah, we all have gods, but seatbelts are kind of a good idea. But she just felt that would be tempting the fates of God to wear a seatbelt. There are people in populations that have that view, and you really need to work with that, and you really need to channel your efforts to take away some of that fatalistic fear that they have about disease, that there are better ways to prevent disease. So why is the Western experience different? And you may agree or disagree, and I'd like to hear from you. But the Western experience demonstrates benefits of implementing infection prevention policy by savings to our government. Remember I said perhaps CMS is still punishing us because we don't get any money if a patient gets an infectious disease while in our care. So that's sort of a monetary carrot and stick out there. I will give you this much money to treat, I know some of you are working on C-sections. I will give you this much money to treat the woman who has a C-section. But what happens when she gets a staphylococcal surgical wound infection? We won't pay for the cost of antibiotic and extended time. We gave you a certain pot of money to take care of that patient, Now you absorb the rest of the cost in our healthcare system. We are driven by our payer system for prevention. That may not be true in a developing structure of healthcare. It's difficult for them to envision the benefits of any such policy in their environment. And most operational costs are borne by the individuals rather than a national, global coverage of healthcare. And even though people argue about our global coverage of healthcare, and believe me, I'm a one-payer person. I'm a big believer in a one-payer system, so everyone gets health care in this country, even beyond Obamacare. I am also a believer that if you have the wherewithal to buy private insurance on top of that, it should be available to you. But it should not be a requirement for your personal health care. Linking our personal health care payment to our jobs and have it non-transferable, I think, is one of the poor things of our medical society, the way we run our healthcare in this nation. If suddenly tomorrow I lose my job, and that means I lose this great healthcare program that I had with my employer, that's to me not the way to run a railroad. But anyway, where costs are borne by individuals, governments may be providing not the best infrastructure. So we're a little bit different in the Western world, that we have our government as the watchdog on a lot of things. Only policies adapted to local conditions are owned. Going back to that first statement that I had on the slide, Gurdon's Law. If the people around you do not see benefit from what you are trying to show them, it's not likely to be sustainable. You have to get the buy-in. So, global infection problems. This is old data from 2005, but it's really the only data that we have still in the literature. 8.7% of hospital patients suffer healthcare acquired infections, HAIs, healthcare acquired infections. In developed countries, it can run from about 5 to 10% of the patients that come into our system, mainly in hospitals, will develop an infection related to their care. In developing countries, that risk goes 2 to 20 times higher. And in some healthcare systems, it may be as high as 25% of the patients that come in will develop some form of healthcare acquired infection. Over 1.4 million people worldwide suffer from infections acquired in the hospital. Things that are related to our care. How many people here work in a hospital setting? Okay, good. So I have people that can identify with what goes on where infection is concerned in a healthcare setting. Healthcare acquired infection, probably in the 1960s, got the name nosocomial. Anyone know why? It's Greek. The word is Greek, and it means hospital acquired. Nosocomial is home acquired in Greek, but this is nosocomial. And why did we choose to use that name instead of HAI, which is what it's known as now? But why did we choose to use nosocomial? Because nobody knew what that word meant. Only the in-crowd knew. And, if you were a healthcare provider, you knew what that word meant. But if you were Aunt Helen and Uncle Peter on the street, you didn't know what that word meant. And that's exactly the way we wanted it. Because it was our dirty little secret in healthcare that it could actually be dangerous to come into a hospital and have care provided. You could, all my career when people would ask me, what do you do? And I would try and explain it. And I usually boiled it down to this. What I do is trying to prevent us from harming you, or even worse, kill you when you come into our care. That's what I do. That's the basic answer. I try and prevent harm from the health care we are providing you. And truthfully, isn't that really what everyone who provides health care should be doing? To do no harm, the classic statement. Infection occurring in patients in a hospital or other healthcare facilities in which infection was not present upon arrival. Now, you'll have many people who loosely understand the germ theory of disease, but they might be doctors in the hospital, will say, that patient had that when they came in. I did not cause that. Maybe, but I don't think so. There's a reason we call it a surgical wound. If they didn't have surgery, they might not have that wound. Yes, they could have been colonized. They could have had that bacteria on their skin. But don't you do something to prevent the bacteria from migrating into the open surgical site? So you see, sure, you can say, I'm sure they were carrying that staph. That's a microorganism for those of you who you're not in that line of healthcare. Sure, they maybe were carrying that staph on their skin, but what happened to asepsis to make sure it didn't enter the surgical wound? It's a healthcare acquired infection. So those of you who are not familiar with this, I love history, so we're going to do a little history here, and I will let you try and guess who these people are. So who's the first guy there with 1684? Who is that man? Any guesses? I've given you a big clue on the other side there of this slide.
Leeuwenhoek.
You've got it, von Leeuwenhoek, the Dutch scientist who invented the microscope. As a little side, these bottom two pictures, let's see if I can, these bottom two pictures right here, this is by a famous Dutch painter called Vermeer. Some of you are probably familiar with Vermeer from his famous painting, The Girl with the Pearl Earring. But this is Vermeer's painting of who he called the geographer. It is most likely von Leeuwenhoek. They were in Leiden at the same time. The families knew one another, and it ended up that von Leeuwenhoek was the executor of Vermeer's will. So there's a very good possibility that the model for these famous paintings of the geographer was indeed von Leeuwenhoek. And he also was part of defining this machine right here, device, called the camera obscura, which was a lens that would focus a view down on a sheet of paper or a white surface, and then it was suspected that painters would paint from that. Essentially, they would project an actual scene with the camera obscura, and then, you can see that when you get into the detail of a Vermeer painting, that perhaps it was more than just his watching the surroundings, but that he had some method of making it so precise. But I think it's very interesting that von Leeuwenhoek ended up being the executor to the Vermeer family will. So let's go on from there. Not a lot of infection prevention happened between von Leeuwenhoek and 1796. Any idea who that is? Smallpox. He's an Englishman. That is Jenner, who first made the connection that the milkmaids did not get smallpox, that they were contracting cowpox from the animals they were working with, and then they did not demonstrate smallpox. They had an immunity. That is why all of our preventatives are called vaccine. Jenner named it from the Latin word for cow, or the Spanish word for cow, which is vaca, or vaca in Latin, vaca in Spanish. That is the root word for vaccine, and that is Jenner. What I find interesting that I never knew was that victims of smallpox included Mozart, Beethoven, Queen Elizabeth I. You remember Queen Elizabeth was the woman, she was Henry VIII's daughter, and she had the bright red hair, and she always wore this white pasty makeup in the paintings. I mean, she looked like a ghost. It was covering smallpox scars. That's why she wore that white pasty makeup. Joseph Stalin, who did not cover up the pockmarks on his face, he had smallpox, as did our first president, George Washington, and Abraham Lincoln. I never knew that Abraham Lincoln had smallpox, but indeed he did, and survived it. So moving on from Jenner, and by the way, is there smallpox in the world today? No. That is by far one of the most successful World Health, CDC, cooperative nations eradication of a disease ever. Now, Jimmy Carter's Institute is working on guinea worm. The Rotary clubs of the world are working on polio. But when I think it was the Cook and Somali was the last known case of smallpox in the world. And then we come in and do all of the vaccination and herd immunity, and it did not spread. Now, there are still research laboratories that maintain smallpox virus in their collection. But I am not one that fears that. I don't think that bioterrorists really could spread smallpox, because there might be some isolated cases, but we would just swoop in with a global vaccination effort and stop it right there. So I am not uncomfortable with the countries that still hold a cachet of smallpox virus. I think it will remain there. I think we should always keep it for research purposes. But I'm not worried about it spreading. So in 1847, who's this guy? He was Hungarian, but he studied med school in Vienna and started his career in Vienna. He had a friend that died after he was cut with a scalpel and got an infectious disease, and he died. His friend's own autopsy showed a pathology similar to that to the women who were dying after childbirth. Any idea who this guy might be? Semmelweis, Ignaz Semmelweis. And I will tell you, from reading many things about Semmelweis, he is the father of modern infection prevention. But he was also a wacko beyond belief. He probably needed a course in quality and communication, because when he put the pieces together of how the women were becoming infected in childbirth and then dying after delivery, he would run through his own hospital screaming that his colleagues were murderers. Probably not a good QI program. He was resented. He was accused of not having his own thoughts together, and he went back to Hungary. And more about him later, because he was more of a visionary than he was even given credit for. He immediately proposed the connection. And remember, this is way before the germ theory of disease, 100 years before the germ theory. He put together that the contamination from these infected patients, the women that had delivered, was being spread by the healthcare provider to the next woman. And he didn't have any concept of germ theory of disease. So, very visionary. But we'll talk about him a little more later, because I think he's also the father of modern epidemiology and perhaps quality. You know, way before anybody else thought about this. So, this guy is the modern epidemiologist. Who is this? Jon Snow. I'm happy that you do know who Jon Snow is more than any of these other people in healthcare. Jon Snow, the famous Broad Street pump. You know, he did this. He did the epidemiological map which is up here. Are we seeing that? We're seeing it there, but we're not seeing it down there. Okay, so he did the map here of the cases of cholera, bringing it down to the epicenter right here, or this sort of wonderful English woodblock of the specter of death surrounding the pump with little children. They had a good sense of humor then. This is his epidemiological map of where the cholera was coming from. And of course, it was proved to be true. It was the water and the waste system mingling. This is one of the single most important infection prevention discoveries of modern time, or ancient time. The fact that this inspired people to clean up water systems, to look at communication between sewage and water systems, was one of the great wonders of modern science. It's probably saved more lives than anything we can do. Just cleaning up your sanitation and your water supply saved countless lives and still saves countless lives when you can do that. I'm sure a lot of you are involved in water programs. And you see it even in modern times when water programs will become contaminated. Possibly not with life-threatening diseases, but if you've ever lived through an outbreak of cryptosporidia in a large major city water supply, and if any of you from Milwaukee are well aware of that, it's a huge, huge public health problem. When I once gave a lecture down in Chicago when there was that cryptosporidium outbreak in Lake Michigan, and people were jumping up and leaving the lecture, about 200 people in the room. They were jumping up and running out to the bathroom a good part of the lecture. Cryptosporidium is, if you're healthy and your immune system is good, it's not going to kill you, but you're going to be pretty unhappy while you have it. So cleaning up the water system was one of the most important things we ever did in public health. So who was the lady in 1855? And remember, you're sitting here in the nursing school. Florence Nightingale. And I love the Longfellow poem, "Lo, in the house of misery, I see a lady with a lamp. I see pass through the glimmering gloom and flit from room to room." And that statement is posted in most nursing schools. In fact, a lot of nursing schools' pins will have the lamp on them, because that's Florence Nightingale, who really put the picture together as an epidemiologist. The work she did in the Crimean Wars was incredible, the way she studied infectious disease in the patient population from the war. She was the first that said we've got to look at the environment. We need to have fresh air. And remember, people are still believing in miasma, term bad air. That's why you go high in the Swiss Alps to get rid of TB. You know, better air up there. Well, we all know that's not going to cure TB. But back then, they thought good air would make you well and bad air would make you sick. So she was the one that opened the windows and said, patients need air circulating in these wards. They need light. They need to be warm. They need a quiet environment. And they need a better diet. She put it all together and brought in the socio-technical aspects of opening up a window and feeding them, that people who are nutritionally compromised do not heal. So, an amazing piece of study by Florence Nightingale. Now we finally get to the point of germ theory in 1861. Do we know who this Frenchman was? It's Louis Pasteur, who put it together. And a lot of his applications, he was working on medicine and surgery, but he also saved the silkworm industry by defining the causative organism that contaminated the silk cocoons and destroyed the silkworm silk business in the world. We are still using techniques today in silk production of the cocoons that Louis Pasteur described. He was the first to know about that. He was also the man who had a theory of fermentation and a theory of infecting patients with bacteria. An interesting fact, 2 of his daughters died between 1859 and 1865 from typhoid, a bacteria. He could not define his infectious agent using a microscope in the water or anything like that. Well, we now know why. If I was to take some water that might be contaminated at the level to cause disease and put it, just a drop of water, under a microscope, it would be very rare that I could actually see an organism. You have to concentrate down water samples to find the organisms, because what might cause disease is too few of an organism in a water supply to be seen just throwing a drop of water under a microscope. You'd miss it entirely. You'd look at the water and say, oh, that's fine, unless you got lucky and saw one. But that's why we culture things, to grow up the organisms. So he's the germ theory of disease. Still, a lot of people don't believe it, but I think it's pretty well established. Who was the next guy in 1867 that did infection prevention? Some of you even may use a mouthwash named after him. Lister, Joseph Lister. He was considered by most to be the father of modern surgery. He was the man that defined surgical asepsis, sterilization, decontamination, disinfection. By 1876, Koch from Germany formed his postulates, which, by the way, are not all that applicable today, and I'll tell you why. You have to find the organism in abundance in all of those people that are suffering the disease, but they should not be found in healthy individuals. Well, there's his first flaw. Now today we know that healthy individuals can be in a carrier state. They can be in a colonized state. For instance, I may indeed be carrying methicillin-resistant Staph aureus in my anterior nares. There's a good chance at any given time someone working in a hospital setting where there's a lot of antibiotic pressure, which I'm sure the pharmacists will talk to you about, but they could be carrying a multi-resistant organism and not infected by it at all. But without good hand hygiene, I might be able to spread that to the person that I was caring for. So you see, Koch's postulates don't really apply there, because you can be healthy and still be a carrier of an organism. People carry salmonella in their GI flora and don't demonstrate the disease at all. But yet with bad hand hygiene, they can pass it on in food preparation or care. So you don't always have to demonstrate it. Cultured organisms should cause the disease when introduced to a healthy organism. Microorganisms must be re-isolated from the person that it has passed to. Well, back then, he didn't deal with viruses. There was no culture for virus. So Koch's postulates, where viruses are concerned, are hard to prove. So 1928, and this is my last person in infection prevention, and I'll tell you why it is the last person in infection prevention. Who is that guy? Fleming, exactly. He was the scientist who found penicillin. Now we have a cure for infectious diseases. This is my favorite thing. Winston Churchill had pneumonia, and the British press said he was saved by Fleming's discovery of penicillin. The truth of the matter was, Winston Churchill never took penicillin. He was saved by sulfonamides. That is what cured his pneumonia. But the British could never say that he was saved by sulfonamides, because that was BASF, the German chemical company. And they were about to enter into a major war with Germany. And England had not forgotten about the First World War that they were involved in with Germany. So no Brit would ever admit that a German discovery had saved their prime minister. It was penicillin. It was not penicillin, it was sulfonamides that saved him. So with Fleming, it was the beginning of antibiotics and essentially the end of infection control. Because now we could cure infectious diseases that we had caused in healthcare and other places. And we didn't care about prevention because we had a drug. We could save people. So we don't care about infection prevention anymore. And to this day, that still occurs. Of course, now we realize we're running out of antibiotic. We have so much resistance in the world. We're running out of it. And we better go back to look at prevention and how to keep people from acquiring these organisms, because the organisms in healthcare today are, quite frankly, frightening with the resistance that they are demonstrating. We don't know how to get rid of the Klebsiella carbapenem-resistant Enterobacteriaceae. We don't know how to get rid of that organism. Nothing we have treats it. Some people recover, a lot don't. So we've gone back to everything prior to Fleming to try and prevent rather than rely on antibiotics, because that didn't work out very well for us. Lack of reliable data, and this is where Victor Rosenthal from Argentina comes in, affects the estimates of the burden of illness worldwide. It was Victor who decided that his main research interest in infectious diseases would be to do surveillance with his colleagues around the world, not U.S. colleagues or English colleagues or French colleagues, but rather the people that were dealing with countries' medical status that were similar to South America. And then more and more people from transitioning healthcare programs in nations came on board with Victor. So he probably has the world's largest data collection on infections of anyone. And Victor is very generous with his publications and what he's doing. And if one of you knows you're an infectious disease person, you're epidemiologist, you're infection preventionist, and they're not a part of Victor's system, you need to be part of his data collection, because he will give you back information that is just worth its weight in gold. And he does this all for free. So we've been through this about how it can be much higher in transitioning healthcare. Inadequate infection prevention infrastructure is a problem in the transitioning healthcare system. A lack of strategic direction, and this is where QI comes in and is so important. Because you can run down a blind alley and think you're going the right direction for infection prevention and run into a wall. It didn't work at all. So QI initiatives in the planning of your infection prevention are so very important. Well-organized, effective infection control programs are often confined to academic institutions in a developing system. It needs to be out in all areas of healthcare. Smaller hospitals, and this is true in the U.S. too, as much money as we throw at it, smaller hospitals in rural centers have less resources. You know, over there, next to us, we have at least 5 people doing infection prevention. If you go 10 miles outside of Madison in an under 50-bed critical access hospital, you'll find one person who is usually a nurse who wears at least 3 hats trying to do infection prevention. Yes, she has under 50 or he has under 50 patients in the hospital at any given time, but are their problems any less urgent? No, they're not. And we have 5 highly trained people over here, including 2 doctors. And out there, there's one person who's trying to do employee health, risk management, QI, infection prevention, all in his day by himself. So, inadequate programs, lack of microbiological support. That's part of prevention too, that you have to have the laboratory available to help you when you think you do have a problem. Microbiology is important. It just doesn't seem like a good idea. It is a good idea. You need the microbiologist working with you. And availability of antimicrobial agents, hand hygiene products, and we're going to do that a little bit, and hand washing facilities, and personal protective gear for prevention. Now, I have worked in settings where I have seen chemicals, disinfection chemicals, provided by the manufacturer. And I've walked in and I've seen it and I've said, really? You're really using glutaraldehyde for that? Oh, yes. And I won't mention a company's name, but somebody who was first on the market producing big bottles of glutaraldehyde. They were using it for a surface disinfection. They were wiping things down with glutaraldehyde. Very bad chemical to use with humans. You know, that is not something you want to spread through the environment. But the company had done a very good job of convincing them that it was a wonderful antiseptic. Well, it's like using a bomb, you know, where a firecracker would have worked. It's not to be used in that manner. But they gave them cases and cases of it. And you really looked at it and said, I don't think you want to use that. Maybe over here in surgery to soak some instruments that can't take heat. And by the way, steam under pressure is what you want to use. But there's nothing harmful to the environment or the people doing it short of thermal burns from taking things out of an autoclave too soon. But it happens. It may have happened in your practice area where you get all this stuff for free. Well, there's a price that comes with it. So be very careful about that. I have seen things that they had given out that actually had antibiotic in it that people were spreading. And once again, I don't think you want to do that. You know, one of the most successful countries in the world where control of antibiotics is concerned, Denmark. My colleagues in Denmark, when we were at an antibiotic resistance conference held in Toronto, an international conference, and my colleagues in Denmark said, we do not have methicillin-resistant Staph aureus. And I said, oh yeah, you probably don't know you have it. No, we do not have it. And well, remember, Denmark is a very small country. They just put out rules that you could not use the antibiotics that we know are precursors to causing, you know, the 110th generation of cephalosporins or whatever, that cause antibiotic resistance in organisms. Denmark just had a draconian rule. You are not prescribing it. End of subject. And guess what? Danish hospitals do not have a methicillin-resistant Staph aureus problem. So they just sort of shrugged their shoulders and said, you just tell them not to use it? And I'm thinking, oh yeah. but they were quite successful. And they got in on the ground floor to do it. 6% of infection can be controlled by minimal efforts. Just minimal efforts. For those of you who are just coming in, I'm talking about infection prevention as a QI issue, and how you can work in QI and make a huge difference with infection prevention. And I'm not calling it infection control because I don't believe in controlling infections. That means a person already has it. I believe in preventing infections. 32% of infection can be prevented by a well-organized effective infection control, infection prevention program. Just like Jon Snow changed the Broad Street pump. There was no hospitalization, there was no antibiotics, there wasn't even any disinfectant. It was changing the water supply. This is true today in modern infection prevention programs. 32% of these infections can be prevented by even surveillance, that people even know they have the problem. Audit process and outcome is surveillance. Unsafe practices, wasteful practices, divert your resources away from where they should be going. You go to evidence-based practices and cost effectiveness, and you reduce infection rate to an irreducible minimum. Very simple. Very hard to do. This is from Damani's work, and he is from the Middle East, and I cannot remember which country he's from, but he's done a tremendous amount of work in developing healthcare systems and infection. And I've included some of his papers in the PDFs that that you have. Routine microbiological cultures. This, when I told you I worked in the Russian system, this was one of the things. They had hospital sanitarians that would walk in and do this on the walls and then take it over, put it on a plate, and then hold it up and say, "You have bacteria. You are fined a certain amount." There was no definition of how the bacteria got from the wall into the patient. But the mere fact it could be found on the wall defined that your hospital has a problem, we will charge you such and such a fine. Hopefully, people are not doing environmental cultures unless they are epidemiologically significant. The day of swabbing surgical goods, saying it contaminated, not contaminated, that should be over. What you should be doing is making sure you have a good monitoring process on your use of disinfectants and sterilization. You monitor. You don't culture to say, oh, this is clean, that isn't clean. You put your trust in the system and the process rather than culturing for outcome, for proof. Remember when I said in the beginning, don't waste your money on clinical trials. One, clinical trials in infection prevention are very costly to do because of the number of people you need in the clinical trial. You don't know where you are on the curve unless you have a huge number in that trial, and they're very expensive. There's no reason to go, and it would always irk me when I would get these papers for review of someone who went out and looked at 100 patients and said, this is proof that that doesn't occur. First of all, you'll never get proof. What you'll get is a likely association of cause, but you will never have proof of cause with that small a number. So study the process rather than the outcome. That's where you'll get your bang for your buck in infection prevention. Unnecessary things. Wearing overshoes or mats that attract dust, sticky mats that you walk in. Now, all of what I'm saying does not apply if you have a hemorrhagic fever outbreak you're dealing with. Ebola, Rift Valley, whatever. This doesn't apply there. Booties, mats, the whole 9 yards, because we don't know for sure about colonization of the healthcare provider, both for their own safety and for the safety of the person that they are treating. When you have hemorrhagic fevers and people are in end-stage disease, it is very difficult doing infection control unless you are suited up in full garb. In fact, the people, Doctors Without Borders, were probably better at it than most developed healthcare systems that came in to help. They learned a lot from the people that were there with the Doctors Without Borders. Scrubs outside the operating theater. Scrubs in your healthcare system are comfortable clothes. Scrubs in our healthcare system are comfortable pajamas for the staff and residents. There is absolutely no reason to wear scrubs outside of an operating room. That is what they were designed for. They were not designed for the emergency room. They were not designed for dialysis. They were not designed for the ICU. Now, they're a status thing, wearing scrubs. But when I watch residents mowing their lawn over just across the street where they are renting a house, and then walking into the operating room and putting on a sterile gown over those scrubs that he has just mowed his lawn in, that isn't a particularly good idea. And a lot of people wear scrubs because I work in the ER. I get scrubs. We use scrubs. And by scrubs, I mean those blue, comfortable pajamas that people like. They're wearing them too many places. It's a huge healthcare cost to provide scrubs where they aren't necessary. Operating room, yes, get the people to change out of them. They are not meant to. In fact, early on, my old boss and colleague and I studied people shedding through muslin scrubs, cotton scrubs. The longer you wear them, the more bacteria comes through them. So you don't want people wearing the same scrubs for 48 hours. Get out of them. You know, put on fresh scrubs if you're wearing them where you need to wear them. Excessive use of IM and IV injections. Insertion of indwelling devices that don't need to stay as long as we leave them. Every time you put a hole in a patient, whether it's with a catheter, whether it's with a tube, whenever you breach the integrity of that patient with some device, you are opening up a portal the size of the river in the Grand Canyon for bacteria. Leaving the device in too long is probably one of the most important things we can do for prevention. You can't get an IV-associated infection if you take the IV out. You can't get a UTI if you remove the urinary drainage catheter. First rule of risk management, stop doing what you're doing, and you'll prevent a bad outcome from it. People leave lines in, whether it's just blind neglect or whether it's convenience. I've seen people leave central lines in a patient well beyond, and that's a pretty big catheter that goes down right into the big veins in the heart. They leave them in. And they say, well, I don't know, we should leave it there in case we need to force an infusion, in case we need to give blood, in case we need... No, you pull it and you replace it if you need it. By leaving it there, you have set that patient up and opened both doors for the ambient bacteria to come see that patient. Pull them. Put an automatic change order in to have them pulled when they're no longer necessary. And of course, back to Fleming, overuse of antibiotics, both for treatment and prophylaxis. A slight anecdote, the person will remain nameless. I was at a dinner gathering in our neighborhood the other night where an absolutely charming surgeon was there, and we were talking about some infectious disease, and she said, well, I have blah, blah, blah that I'm going to take for it. And I said, did you contract this? She said, no, it's just for prevention. No. If you don't have it, don't take. And her reasoning was, well, I'm a surgeon. I have to be in surgery, and I can't possibly be colonized with this. And I just said to this person who is nameless, you're going to be colonized with worse things if you keep up that behavior. Prevention. She could write the script, so she did. Don't do that. Don't let your people do that. 35% of our total health care budget is spent on antimicrobials in the U.S. 11% in transitioning healthcare systems. No-cost measures for good infection control. Aseptic technique with all sterile products. Do a QI on how your reprocessing of instruments and supplies are going on. Understand that system of where there might be flaws. One of the most common areas where there might be flaws in reprocessing is the demand of surgeons wanting the instruments now and in my hand. So your processing gets compromised to get them up to the operating room faster. You know, I don't want to hear about the people that are reprocessing it. I need that instrument case cart right now because the patient is going to go under anesthesia and I'm ready. Well, the people that are reprocessing all of those instruments may not be ready. So they rush the procedure. And what happens when you rush a procedure? Steps are missed. Steps are missed or compromised. So that's a great area for QI. Isolation of patients with communicable diseases with a multi-resistant organism. Many times these patients come in, and maybe by the third day, we discover through the culture that, that is a resistant, vancomycin-resistant enterococcus this patient has. Well, did anybody do the history on the patient to know that they had been seen for, let's say, kidney failure and had been in dialysis for a year, blah, blah? There's a good chance that these people may be colonized with that organism. Do a surveillance culture if you have a high suspect that they have been exposed and may be colonized with one of these horribly resistant organisms. Unnecessary vaginal examination in women in labor. It's unnecessary. Mechanically ventilated patients should be placed in a 30-degree semi-recumbent position. Don't put them flat on their backs. Don't let the ventilation tube humidity flow back into their trachea and their lungs. That stuff is like a cesspool colonized. Always keep them at 30 degrees so the secretions flow down. Same thing is true with the urinary drainage bag. Why do we move patients and throw the Foley bag up on their stomach? That's an automatic drainage back into the bladder by the possibly contaminated urine that's in the bag. Always keep the bag below the bladder. But it's easier to transport the patient if you put the bag back up on their stomach. Simple quality corrections in the system that doesn't take any money to do it. Here's one. Minimize the number of people in the operating theater. Sometimes at University Hospital, I'd go into the operating rooms and we would have a cast of thousands. 4 people that were doing the work, 7 people that were there watching. Med students, nursing students, surgical technicians. When in reality, you needed the circulator, you needed the scrub, you needed the surgeon, and the surgeon's resident or assistant. But the doors were constantly, doors to operating rooms should be closed. That's the way the airflow system works correctly if you have one of those laminar airflows going through it. You don't need all those people. I guess in retrospect, you could say that me being the person in charge of surgical infection control wasn't needed either in that room. But we were looking at possible contamination. And it was everybody trying to get a spot at the table to watch. You don't need that. Education and practical training in aseptic technique and hand hygiene. Appropriate use of PPE. And that doesn't mean everybody in scrubs. Sharps use and disposal in robust containers. Now, when we talk about a system thing with sharps use and disposal, yes?
What's PPE?
Personal protective equipment. Mask, gown, gloves, moisture barrier. Yeah. Sorry, I was using jargon. My mistake. Sharps containers. When we had the bloodborne pathogens rule here, which has to do with disposal of sharps, people installed sharps containers. So when you were done using a needle, a syringe, disposable, you could put it in that container and then it would be taken away in the trash. Great. They were placed at a certain height. This happened to a friend in California. Everything was cool. Everything was working well, except there was a nursing shortage in California. There's always a shortage of something in California, which if you look at it in a systems viewpoint, you would say, what's wrong with California? But there's always a shortage of something in California. Well, it was nurses. So in the Philippines, there's reciprocity. If you are a registered RN coming out of the Filipino nursing school, you have reciprocity with the California Board of Nursing. This is how they handle their short staffing in California hospitals. So they would bring in the Filipino nurses and to practice. And these were perfectly well-trained healthcare professionals, except one small problem. They had put needle containers up here, out of the way of guests and patients. Now, what's the average height of a Filipino? A little shorter than I. I would be a tall Filipino, and I'm 5'2". These men and women were about 4'11". They can't reach the sharps container. They strain to reach the sharps container, and what happens to them? They get stuck by the needle. They can't see the top of the container. They're blindly trying to put the sharps in. A systems issue in infection prevention. Nobody predicted that we would have 4'11" height nurses working in California hospitals. But we got thousands of them when we had a nursing shortage. Had nothing to do with their training. We gave the Filipino nurses an impossible physical environment for them to work. That's what I say, these low-cost systems approaches to prevention really work. Hepatitis B vaccine, post-exposure management, know what to do when someone is injured. Identify the preventable infections and target the areas of high priority. Urinary tract infection, is it a high priority? Well, talk to most physicians, they say, that's kind of white noise. I can treat that with antibiotic and frankly, if you pull the catheter in an appropriate time frame, you can prevent it altogether. But let's say that's sort of background noise for them. But look at the amount of patients that get that. Suddenly it rises higher. Line-associated bacteremia. Not a whole lot of people get that. ICU disease, really. Maybe a little bit in your dialysis population. But most of it's an ICU-acquired infection. Is that high priority? By the number, you would say no. By the severity, you would have to say yes. So, take a look at your infection program. Make it a QI project. And take a look at how you do the checks and balances about what's the simple answer to prevent, how severe is the infection, the sequelae, the outcome, versus how many people are involved. The picture will shift back and forth very rapidly when you do that. Minimum resources, maximum benefit. I would say where infection is concerned, if I were doing that, I would pick removable devices as the first thing to do a QI project on. Figure out how to get those IV lines or those central lines out. Figure out how to get that urinary drainage catheter out. Figure out how to get people off of ventilators in a timely fashion, if you can. Absolutely costs nothing. It's a study of intervention. And I'm going to wrap up very shortly here. And we're just going to, you know how to do all this. Severity versus frequency. This is a great diagram if you ever really want to say, well, is this really important? This is how we have always prioritized risks. In this square, how severe is it? How frequent is it? I can take the axis on this and change that to what do we agree on? What don't we agree on? I can do that way. And you can look at your policies and procedures in that function. Do we all agree on the way to set an ankle? We probably do. Probably all of us have a pretty good protocol for setting ankles. So that's going to be pretty much a low-risk procedure. Do we all agree what to do with a critical care patient? No, we don't. There are many ways. That's probably a risky decision. It borders between knowing exactly what is safe and chaos at the other end. So let's be political for a second. Where would you put war between humans on that spectrum? It's chaos. Nobody knows what to do with it, and no one is in agreement on how to do it. War is the ultimate chaos. But I can tell you, ICU care just comes in a little from war, about where people have varying ideas of how to deal with it. Effective and feasible interventions. You can read these. I'm going to run through this. It's too complicated. Neonatal sepsis among NICU. This is a study that was done for the IFIC conference in Malta. This is Egypt. I've included some of this in your handout. This is a wonderful of sepsis among ICU infants. A study done in Egypt. Mortality rate at the time they studied it was 55%. And placing the infants on IV fluids and antibiotics, and the way they did it reduced the mortality to the level recorded in developed healthcare systems. Poor understanding of infection control, unsafe practices with IV fluids. They reuse the individual bags of fluid on multiple infants without any sterilization in between. Opened fluids became contaminated with Klebsiella, which if you are in hospital care, you know that's one of the resistant bugs today. The NICU environment surfaces, Klebsiella was the predominant organism that they retrieved from the surfaces. This is a place for very specific culturing of the surfaces. When you know you have a mortality rate of 55%, you better be looking at everything in that ICU. This is more about the training, and you can see after the QI and infection prevention training how their mortality rate dropped in this Egyptian ICU. Hand washing. Children under 5 years of age, 50% lower incidence of pneumonia. This is from Karachi, Pakistan, with just soap and water. Children under the age of 15, 53% lower incidence of diarrhea, 34% lower incidence of impetigo by just hand washing with soap and water. Ventilator-associated pneumonia, the reduction of days by the Aga Khan Hospital in Karachi, Pakistan. All of this is in your handout to read at your leisure. Central reprocessing and supply of medical devices in all of your healthcare facilities are ripe for QI projects. Great projects for prevention. This is DTA Pate's work at World Health about the 5 moments for hand hygiene. And this is the last thing I'm going to leave you with. This is what DTA's group in Geneva put together about when you use hand hygiene for best infection prevention. I would ask you one thing. In human factors, we do what is called a shared mental model. Do you think like I think? Maybe. I don't know. Do you think like I think? I don't know. What we need to do is to decide upon a practice from our studies that brings you and I together about how we collectively think. It's called a shared mental model. And unless you have that, you have a problem in the system. We all need to look at it and decide this is the way we will all do it. Now, by sharing it, what I'm doing may actually not be as good as what you're doing. You may have a few tweaks in that system that are much better than what I'm doing. But by sharing it, then we pick up on our strengths and our weaknesses, and we all do it the same way. I would propose to you that this is one of the most important things in hand hygiene. Now, how are you going to do this? Well, here's a very simple thing. You all know what Post-it notes are some form of a product that's like a Post-it note. And by the way, the number one product that 3M sells is not Post-it notes. People always say, oh, what's 3M's number one product? Post-it notes. No. It's reflective highway markers that you all have in all of your countries. That technology is owned by 3M. Those reflective yellow markers along the sides of highways, that's their most important product that they sell the most of. But Post-it note is right up there. So here's what I want you to do. I want you to take different colored Post-it notes or some product like it, write an L, an S, and an A of the various colors. And I want you to pick a unit in your healthcare organization and say to the staff on that unit, here, put these in your pocket. And when you do hand hygiene, if the soap wasn't convenient to you, or the alcohol hand rub wasn't convenient to you, or the lotion that we provide you, and hand lotion is important to provide because you want control. You don't want them bringing in some product from their home. There are lots of outbreaks associated with home products being brought into the healthcare setting. But if you think it isn't in the right place, take out that Post-it note and put it where you want it. And you do this, and you collect them about every day. So you don't leave them up in the patient room all the time. But you will start to see a pattern by the people who actually do the work, or as the Brits say, the people at the coal face. A mining analogy that I never got, and then I realized what they were saying. You'll see that there's a pattern to where your people need that product to perform what they consider safe patient care. Do any of you think you could do that project? If you're in healthcare? I mean, obviously, if you're with the Ministry of Health, you're not going to do that in your office. But if you are actually at the front line working in healthcare in your facilities, that is not expensive to do. That is an inexpensive project. It is easy to do, and the people who are actually providing the care will show you the path of your process that you need to put in place. Too often, we come up with great ideas that the people that we are giving them to have no input on. And then, my first slide, if those who are actually doing the work do not benefit from what you're saying, they won't do it. Here's local production of hand in Mali. Who says you have to buy prepackaged alcohol hand rub? There's no reason that you can't make it yourself. The only thing you have to worry about in non-sterile alcohol, and by the way, these hand hygiene products that you get, they're not all sterile. It's hard to sterilize alcohol. Can't heat it. So, bacillus is the one thing that you have to worry about. Spores of bacillus will live in hospital-grade alcohol. It'll also live in gin, too, but I don't know that that's important to you. But bacillus spores will live in alcohol. This you've seen. This is our model that we developed here in the unit that I worked in. And I will just say to you that this is how I got interested in it. I call this the Bermuda Triangle of healthcare. We look at the person, we look at the tasks they do. If something doesn't work out, and in my case it's infection, if something doesn't work out in that task, we go right up here. We retrain them, the way we always train them. If it still doesn't work out, we buy them new tools and technology. We're going to get you the newest IV pump. Then I know you won't have any problem. What if we went over here and looked at the environment of here? That's the physical environment, not the mental, but the physical environment that you're trying to do it in. If there's no room in that ICU bay for the equipment, is the healthcare provider better off with the new technology or worse off? I would would propose that they're worse off. Because now they're trying to learn a new piece of equipment, which, by the way, we've given them no time to learn. You know, it's a see one, do one, teach one on the unit. And they're doing it in an environment that is so crowded they can't even get to the device. Or the device is in front of the hand hygiene sink. So no one can get to good hand hygiene. We only concentrate predominantly here. What we need to do is go over here and look at our organization. That's the management structure and the environment that we're doing it in. And if you notice here, all of these arrows have two ends. It's a flow. Probably Leslie didn't say this to you because she wasn't trained in it like I was, but she went to a very good program I went to, which I always think is a better program. But the system is a balloon. If you push the balloon in here, that air doesn't disappear. It's got to come out somewhere else. Always remember the balloon analogy. If I change something here and push here, the balloon is going to pop out a little bit more over here. It's in constant flow. It is not static. That's why these arrows have 2 points on them. It goes around constantly. Now, if you put it in here, what's this up here? This is the original Donabedian model. Structure, process, outcomes from the 60s from the University of Michigan. This is Dr. Donabedian's original quality process here. We propose that this part, which contains our model, fits under work structure in the Donabedian model. Okay, I am almost finished here. So, remember the model that I just showed you. And remember we talked about Semmelweis, that he had a little communication problem with his colleagues. He was not easy to work with, but he was spot on when it came to knowing what caused the childbirth fever that killed so many of the women. So what was the model? Let's take it to that SEEPS model. You have the person, that could be the woman or Semmelweis or the medical students, whatever. They were only in on the side of the hospital. The midwives stayed over on this wing of the hospital. But let's go a little further back in the person. Who was the mother that was giving birth? She wasn't a rich woman unless she got into complications. Then she came into the hospital. Rich women had their babies at home. So describe a rich person in that time in Vienna. They had decent hygiene. They were living in a house that was not multi-family. They had a single apartment. They had good nutrition. They were well fed. And they had good sanitation. Who went into the hospital? Poor people. So they were immunocompromised by their socioeconomic status to begin with. They didn't have the good health that the woman who lived in her own Viennese apartment did. And this is great. Whether you were rich or poor, if you were an unwed mother, you had to go into the hospital. Which I just find historically fascinating, that unwed mothers went into the system instead of staying at home. So, that's the person. Now, what's the task? Delivering children. You've got the midwives over here doing it, and you've got the doctors and the med students on the other side of the hospital, other wing of the hospital doing it. The midwives, if they got into complications, sent their women over to the doctors and med students. Everything was fine for a while. And then suddenly the doctor's side got an infection rate of 99% mortality, which I think we all agree is not an acceptable rate of mortality. Same tools, same environment in that hospital, same task, but the doctor's side really had problems. Physical environment, water color, everything, ventilation, patient crowding, was the same on both sides of the hospital. Difficult extended labors had to go over to the physician's side. They were taken away from the midwives. In use, comparing the hospital and at-home deliveries, the tools and technology were far different in the hospital than at home because these were natural births. Physician medical student, midwife, patient. Those are the patients, are the people in it. I would propose to you that the mortality in Semmelweis's study, and he proposes this too if you read his whole doctrine, was one of developing advancement in medical technology. You would know the story about disinfecting the surgeons and the med students' hands, but how did they get there? Very simple. This hospital in Vienna was one of the preeminent medical schools in Europe at the time, the Viennese hospital. They were like the Boston hospitals of Europe. And they wanted everything that was new and interesting and hot to be there first. So those of you who do not know the history or haven't studied the history of Western medicine know that the Catholic Church had a lot of influence. And one of the things the Catholic Church absolutely refused to allow was the disassembly of bodies. It was not permitted. But there were groups of doctors who were anatomists that secretly would dissect bodies. Grave diggers made a great amount of money providing dead bodies to medical schools, to predominant medical schools, so people could do anatomy. And they knew that by the fact that they couldn't open up a body was really constraining their understanding of medicine. So you've seen paintings from the 1700s of where everybody's looking down on a cadaver on a slab where one man was performing an autopsy. Vienna decided to push the edge of the envelope, and remember the Viennese Empire does answer to the Church of Rome, but they decided to push the outside of the envelope and say, we have an institute of anatomy. And, of course, you have a medical school structure, which is pretty much the same today. The dean of the medical school is the Holy Roman Emperor, and then it goes down to various knights and landowners, etc. That's the structure of a med school even today. They said, I am requiring you physicians working in my hospital that you will go with your patient that has died in my hospital to the Institute of Anatomy. And these aren't clinical pathologists, these are anatomists back then. Clinical path didn't exist. You will go and you will do an autopsy